Namaste Vidya, Hamesha Kush Raho Vidya. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University. This is the series of thyroid disorders, part 3. In the previous two lectures, we have discussed about hypothyroidism. And in today's lecture, we are going to discuss about thyrotoxicosis. What is thyrotoxicosis? Etiopathiophysiology, clinical features. We will also be discussing about Graves' disease today, investigations and management. So let's start with the thyrotoxicosis. Thyrotoxicosis is a state of thyroid hormone excess. The etiology of thyrotoxicosis is variable. The hyperthyroidism that is caused by Graves' disease, toxic multinodular goiter, and toxic adenomas. We have three types of conditions that are commonly seen in thyrotoxicosis. We have primary hyperthyroidism, thyrotoxicosis without hyperthyroidism, and secondary hyperthyroidism. Three conditions: primary hyperthyroidism, thyrotoxicosis without hyperthyroidism, and secondary hyperthyroidism. Primary hyperthyroidism consists of various conditions like Graves' disease. We have toxic multinodular goiter, toxic adenoma, struma ovary, and drug iodine excess, that is jot-based off phenomenon. Graves' disease, toxic multinodular goiter, toxic adenoma, struma ovary, and drugs, that is iodine excess, that is seen in jot-based off phenomena. Now we come to thyrotoxicosis without hyperthyroidism. In thyrotoxicosis without hyperthyroidism, we have subacute thyroiditis, silent thyroiditis. All these things will be covered in the next lecture with thyroiditis. And there are other causes of thyroid destruction like the radiation. We have infarction of adenoma. There is also ingestion of excess thyroid hormone that is seen in thyrotoxicosis, factitia, or thyroid tissue. Next, we have secondary hyperthyroidism. Secondary hyperthyroidism is seen in TSH secreting pituitary adenoma. Secondary means other than the primary phase. In secondary hyperthyroidism, it is due to some other factor that is not directly related to the thyroid gland, like TSH secreting pituitary adenoma. We have thyroid hormone resistant syndromes that consist of occasional patients that may have features of thyrotoxicosis. We have chorionic gonadotrophin secreting tumors and also gestational thyrotoxicosis. We have various clinical features. We will start with the symptoms first, the symptoms of hyperthyroidism. In the symptoms of hyperthyroidism, we have the symptoms like hyperactivity, irritability, and dysphoria. We also have heat intolerance and sweating. We have palpitations, fatigue and weaknesses, weight loss with increased appetite. We have diarrhea, polyuria, oligomenorrhea, and loss of libido. I will again repeat the symptoms: hyperactivity, irritability, dysphoria, heat intolerance and sweating. We have palpitations, fatigue and weakness. There is weight loss with increased appetite, diarrhea, polyuria, oligomenorrhea, and loss of libido. Now we come to the signs of hyperthyroidism. The signs includes tachycardia, that is atrial fibrillation in the elderly. We have tremors, we have goiter, and warm moist skin. We have muscle weaknesses, proximal myopathies, lid retraction or lag, and gynecomastia. So I will again repeat the clinical features: tachycardia with atrial fibrillation in the elderly, tremors, goiter, warm and moist skin. We have muscle weaknesses, proximal myopathy with lid retraction or lid lag, and gynecomastia. Now we start with Graves' disease. This is a very important topic and very important from the examination point of view. In the Graves' disease, it accounts for 60 to 80% of thyrotoxicosis. The prevalence varies among population and reflecting genetic factors and iodine intake. It occurs in up to 2% of the women, but is 1/10 as frequent as men. It occurs between 20 to 50 years of age. The predisposing factor of Graves' disease are environmental and genetic factors. We have various kinds of stress factors, smoking, sudden increase in the iodine intake, and postpartum period. So we have environment and genetic factor, stresses, smoking, sudden increase in the iodine intake, and postpartum period. Now the pathogenesis of Graves' disease. The hyperthyroidism of Graves' disease is caused by thyroid-stimulating immunoglobulin that are synthesized in the thyroid gland as well as in the bone marrow and lymph nodes. In the long term, spontaneous autoimmune hypothyroidism may develop in up to 15% of the patients with Graves' disease. Now, what is the reason for Graves' ophthalmopathy? There are cytokinins which appear to play a major role in thyroid-associated ophthalmopathy. There is infiltration of the extraocular muscles by activated T cells and release of cytokinins that results in fibroblast activation and increased synthesis of glycosaminoglycans that can trap water, thereby leading to characteristic muscle swelling. Later in the disease, there is irreversible fibrosis of the muscles. The increase in intraorbital pressure can lead to proptosis, diplopia, and optic neuropathy. The other clinical manifestations it depends on the severity of thyrotoxicosis. What is the severity of thyrotoxicosis? The duration of the disease, the individual's susceptibility to access thyroid hormone, and the patient's age. I will again repeat it. The clinical presentation of Graves' disease depends on the severity of thyrotoxicosis, the duration of the disease, the individual's susceptibility to access thyroid hormone, and the patient's age. There is apathetic thyrotoxicosis. It occurs in the elderly patients, mainly with fatigue and weight loss. In the clinical features, the thyroid is usually diffusely enlarged to 2 or 3 times its normal size, and the consistency is firm but not nodular. There may be a thrill or bruit that is best detected at the inferolateral margins of the thyroid lobes due to the increased vascularity of the gland and hyperdynamic circulation. Now we start with Graves' ophthalmopathy. In the Graves' ophthalmopathy, there is a sensation of grittiness, eye discomfort, and excess tearing. There is proptosis. Proptosis may cause corneal exposure and damage, especially if the lids fail to close during the sleep. There is preorbital edema, scleral injection, and chemosis that is also frequent. The muscle swelling results in diplopia. Most serious manifestations is compression of the optic nerve. Next, we have NO-SPECS scoring system to evaluate ophthalmopathy. It is graded from 0 to 6. NO-SPECS, N-O-S-P-E-C-S. You can see the highlighted words. 0 when there are no signs or symptoms. Grade 1 when only signs, that is lid retraction or lid lag, and no symptoms. Second, if there is soft tissue involvement, that is periorbital edema. 3 when there is proptosis greater than 22 millimeter. 4 there is extraocular muscle involvement, that is diplopia. 5 corneal involvement. And 6 we have sight loss. I will again repeat. 0 no sign or symptom. 1 only sign, that is lid retraction or lag. Second, soft tissue involvement. Third, proptosis. Fourth, extraocular muscle involvement. Fifth, corneal involvement. And sixth is sight loss. Thyroid dermopathy. In thyroid dermopathy, we have pretibial myxedema that is most frequent over the anterior and lateral aspect of the lower leg. The typical lesions is a non-inflamed indurated plaque with a deep pink or purple color and an orange skin appearance. There is thyroid acropathy, that is clubbing of the fingers, in less than 1% cases. Now we come to lab evaluation. The TSH level is suppressed and the total and unbound thyroid hormone levels are increased. There is measurement of the TPO antibodies, thyroid peroxidase antibodies. The diagnosis of Graves' disease is straightforward in a patient with biochemically confirmed thyrotoxicosis, diffuse goiter on palpation, ophthalmopathy, and often a personal or family history of autoimmune disorders. The diagnosis is generally established by radionucleotide 99 and technetium, iodine 123 or iodine 131 scan, and uptake of the thyroid. Scintigraphy is a preferred diagnostic test. Now we have the differential diagnosis, the conditions which resembles Graves' disease. In secondary hyperthyroidism, due to TSH secreting pituitary tumor, there is also a diffuse goiter. The presence of non-suppressed TSH levels and the findings of a pituitary tumor on CT or MRI can suggest the diagnosis. The clinical features of thyrotoxicosis can mimic certain aspects of other diseases that includes panic attacks, mania, pheochromocytoma, and weight loss that is associated with malignancy. The diagnosis of thyrotoxicosis can be easily excluded if the TSH and unbound T3 and T4 levels are normal. The normal TSH also excludes Graves' disease as a cause of diffuse goiter. Now we come to the treatment. The hyperthyroidism of Graves' disease is treated by, number 1, reducing thyroid hormone synthesis using antithyroid drugs. Number 2, reducing the amount of thyroid tissue with radioiodine iodine 131 treatment or by thyroidectomy. So this was all about hyperthyroidism. In the next lecture, we will be discussing about thyroiditis. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.